Hi, thank you for having me talk about the direct antiglobulin test, and this will be a mixed bag of cases, and we'll try to make it also interactive for the group. Here's my disclosures. I don't have any. Please provide some feedback at the end, and all images are stock, and I'll include these slides later for you all to review for self-study. This will be like a small group breakout session. We'll have 6 cases, 5 minutes to discuss, and then we will review together as a group. To briefly go over positive causes of DAT, and some of these will be in our cases, we could have a DAT because it's just a normal finding. About up to 15% of hospitalized patients can have a positive DAT. And then you can subgroup it into like two broad categories. One would be an autoantibody, and the second would be an alloantibody, and then there'll also be transfer of antibody. For autoantibodies, our differentials are usually like the warm and cold autoimmune hemolytic anemias. For alloantibody, it's things that are transfusion related, so like acute delayed hemolytic reactions or delayed serologic reaction. We could have hemolytic disease of the fetus and newborn, drug-induced antibodies or passenger lymphocyte syndrome, whereas the transplanted organ B cells start making antibodies and they lyse the recipient's red cells. Then you could have passive transfer of antibody due to like immunoglobulin preparations. That includes IVIG, ROGAM, when it's given to mom and it shows up in the neonate as like an anti-D, or passive transfer of antibody by a transfused product. That is super duper rare. It doesn't really happen because we do not accept red cells that have an alloantibody in them. And then there's other causes like infection, associated cold immune hemolysis, which are listed above. So let's start with our first case. This is a 12-hour neonate in the NICU admitted for respiratory distress or hyperbilirubinemia. They're quite anemic. Their bilirubin is quite high, and the baby is type A positive. There is a DAT that's done on cord blood, and we can see that the IgG is positive. I'm gonna pause this here, and if you're watching this video, again, because it's a practice video, you feel free to pause and then brainstorm the answers to these questions, and then we can continue. So, additional info is mom's blood type is O pos, and then elution studies show that there's anti-A bound to the patient's red cells. So what does that mean? We take neonates' red cells, they're coated with antibodies. We use acid to rip off that antibody and run it on A positive red cells and then agglutinates. So what does that make our diagnosis? It makes our diagnosis be the hemolytic disease of the fetus and newborn. It's when there's destruction of new kind of a fetal newborn red cells by mom's red cells, my mom's antibodies that are specific for paternal red cell antigens. So the mom's antibodies cross over into neonatal circulation, they bind the red cells and cause antibody-mediated red cell destruction. This causes in fetal erythropoiesis, known as erythroblastosis fetalis, and when it's untreated, it can cause worsening anemia, damage to the liver and the spleen, high output cardiac failure, cause hepatic dysfunction and portal hypertension, lead to decreased albumin production, which lowers the colloid pressure inside the vasculature, allowing the fluid to go into the tissues and cause this like edematous hydrops phenotype found in ultrasound. So in HDFN, what are some medications that you specifically want to ask about in these cases? And you could ask about IVIG, because when IVIG is given in cases of HDFN, it can sometimes cause a positive DAT in the neonate. But what's so special about type O moms in babies who are A or B? Well, in that case, type O moms have the IgM anti-A, IgM anti-B, but they also have a type of an antibody that is an anti-A comma B IgG specificity antibody. So this antibody is small enough that it can transfer through the placenta into the neonatal circulation and cause HDFN. And other IgGs that are commonly implicated in HDFN, they are anti-D, anti-Cal, and others. So let's move on to case number 2. Here we have 24-year-old male. They're admitted after motor vehicle collision. They get 2 units of red cells, and then another unit is ordered on hospital day 7 because the hemoglobin is now downtrending. Their billy goes up, the haptoglobin is low, and LDH is high. And then we do a type and screen on them on day 7, and they are positive now for anti-big E. So let's pause here. If you're watching the video, you can pause here and answer the questions, but then, what's the patient at risk for? How would a DAT be helpful? Would an elution be helpful? And what other tests can we do? The diagnosis here is a delayed hemolytic transfusion reactions. This occurs when patient is alloimmunized to minor red cell antigens during prior transfusions or pregnancy. We typically see these 3 to 10 days after a red cell transfusion, but this antibody can develop 24 hours to 28 days. Pre-transfusion testing can fail to detect these antibodies, like in terms of the KIT antibodies due to the low titer, and after re-exposure, there could be either a new antibody formation or an amnestic response that occurs, and then this will cause decreased survival of red cells. So how does this happen? You have initial antibody screen is negative, the patient gets an E positive red cell unit, but their antigen phenotype is E negative. They have an increase of antibody production. This antibody binds to the transfused red cells. It brings it to the liver or the spleen, and they cause hemolysis and the hemoglobin to return to the pre-transfusion level. So what additional tests can give you more information on this antibody? Well, the answer is you could perform a DAT, like the DAT, but then you can also do an eluate and then phenotype the unit that was transfused. So again, similar mechanism here that I wanted to show you, and so just kind of more of like we want to do an eluate and see if the antibody is actually anti-E, because it could be something else or it could be also nothing, and maybe the patient is bleeding for other reasons. So let's move on to case 3. This is a 23-month-old female. They have onset of decreased activity. They have anemia, dark-colored urine. But 3 weeks prior, they had intermittent upper respiratory infections and recent otitis media require antibiotics. The urine looks pretty red. There's some red cells, 0 to 5 in the high power field that we can see in it. Hemoglobins, they're anemic, normocytic, increased reticulocyte count, high LDH, low hapto, and elevated billy. So you could pause here. Here is their DAT. You could pause here in the video, and then we could talk about the differential, the diagnosis, and what tests can help make this diagnosis. Okay, but I will continue in the video in here. So the diagnosis here is paroxysmal cold hemoglobinuria, and this is a rare autoimmune hemolytic anemia that occurs in kids and is often associated with infections like previously syphilis, but now it's mostly associated with viral infections and upper respiratory tract infections. This is due to a biphasic IgG that develops. It's known as Donat-Landsteiner antibody. It binds to red cells in the cold. It it recruits complement C3, C4 to bind to those red cells, and then at warmer temperature it dissociates and activates complement, causing hemolysis. And this is anti-P specific, so if you think of PCH, it's an anti-P antigen specific antibody. And the DAT will show the presence of C3. It will not show IgG because the IgG diffuses away at warmer temperature. P antigen is specificity, and treatment is usually supportive transfusion and to keep the patient warm. These are self-limited type of cases. So What specific test can you do for PCH and how does it work? The answer is Donoff-Landsteiner test. And the way that it works is you take 3 tubes. One is the patient's serum, tube 2 is the patient's serum and normal serum mixed together, and 3 is just normal serum. You take one set, you incubate it on ice. You take the second set, you incubate it at 37, and then the third set, you incubate it at ice at 37. So what you're hoping really, this is a control, this is also a control, and then here what you're hoping is that this antibody will bind at a lower temperature. Then, because you are mixing the patient's serum there, which contains complement, as you move it to a higher temperature, it should activate the complement and lyse those red cells. So if there's a biphasic hemolysin present in tubes 1 and 2, they will be hemolyzed. Let's talk about case number 4. This is a 73-year-old male who has complaints of general malaise, some abdominal and back pain, and have a dark urine and a fever. They're anemic, their T-billy is elevated, LDH is quite high, and they had this generalized lymphadenopathy and weight loss for several weeks. Here is their DAT, and what do you think could be going on with this patient? You can pause the video here or keep going. So in this patient, we have something that's called the cold agglutinin disease. This is another type of cold autoimmune hemolytic anemia. It's cold reactive, but this one though is associated with IgM antibodies. What's special about these IgM antibodies is that they are reactive at a warm temperature. Normally, cold autoantibodies they're not clinically significant at all. Normally, IgM is not clinically significant, but in this case, they are. Here, they bind anti-big I or little I specificity, and when they have specificity, usually like they develop either due to primary or secondary causes. Primary is not very common. It's usually a patient who has an IgM producing B cell clone. It's usually an older adult due to a low-grade B cell neoplasm. But secondary, they're very more commonly to be post-infectious due to mycoplasma, which should generate anti-I antibodies, IgM, and then or Epstein-Barr virus, which generates anti-little I antibodies, which is more common in kiddos. This causes complement-mediated hemolysis, so the DAT becomes positive for complement. Here you, again, avoid corticosteroids. You keep the patient warm, use a blood warmer. You can use a rituximab, and if it's a very severe IgM intravascular disease, you could use IgM. You could use apheresis. So, what other tests could you recommend for cold agglutinin disease? Is you could do an antibiotic titer, which is usually quite high, and it could be greater than 164. And titers, you're just doing a dilution. Another test you could do is thermal amplitude, and that is where the antibody is tested at different phases, like at different temperatures. It's just like it's a fancy reverse back type where we would test it at 30 Celsius, at 4 Celsius, or 10 Celsius. So here you can see the reactivity is at 30 Celsius, but another antibody, it could be a reactivity at 10 Celsius. So that one is not that clinically significant. And now let's move on to case number 5. So here we have a 50-year-old male who's coming in for surgery. Hemoglobin on post-op day declined by 1. Resident orders DAT and hemolysis workup for this drop, but the LDH is normal, hapto is normal, and billy is normal. So what do you think is happening in this case? Well, the DAT can be positive in healthy patients. It could be, the positive predictive value of a DAT with hemolytic anemia is 83, but the positive predictive value in a patient without hemolytic anemia is only about 1%. Some pre-transfusion patients with a positive DAT have non-reactive eluates, and that can be normal. And these patients usually have no signs of hemolysis, and they could be associated with elevated serum globulin levels. So for this case is just a normal DAT. This just shows that a DAT can be normal in hospitalized patients. So next, let's move on to case number 6. And in this case, you have a 35-year-old female who has been having fatigue. They can't perform activities of daily living. Their white count is normal. Hematocrit is 17, so they're pretty anemic. But yeah, they're pretty anemic. The platelets are normal. LDH is high, total billy is high, and hapto is completely undetectable. So you could pause here. Here's your DAT. It's polyspecific is positive, IgG is positive, C3 is positive. And let's talk about the differential here. And would the DAT be helpful? And why would a DAT be helpful? And what do you expect the LUA to show? So I'm going to go on the next slide. The diagnosis in this case is a warm autoimmune hemolytic anemia. This is production of antibodies by the patient against the high-frequency antigens exposed on the patient's red cell surface. When you have an antibody screen for these patients, it will be panagglutinin positive. When you do an eluate, it will also be panagglutinin positive. In about 30% of cases, we don't know why it's occurring. The DAT can be positive for IgG alone or IgG in complement in majority of the cases. The treatment here is steroids, immunosuppressive, drug splenectomy, and supportive blood transfusions when needed, which will be like our phenotype matched. So what would an elution, for example, show in this case? In a case where there is no antibodies bound to red cells, like in a normal patient, and you do an eluate, so you use acid, then you take the acid off and take the antibodies off, and you run it on this 3-cell screen, you wouldn't really see anything. But if you're in a patient, for example, who doesn't have autoimmune hemolytic anemia but has KEL antibody bound, you would rip off the KEL, you run it on the panel, and in the cells that has the big K antigen, it will react. In a patient with a warm autoimmune hemolytic anemia who has antibodies that are non-specific, you will rip off those antibodies, and when you run it on the eluate, it will cause reactivity in all the red cells reagent tested, so it will be very non-specific. So again, we reviewed, because this was just a practice run, I went through it pretty quickly, we reviewed all of these cases in green, you can see right there. So yeah, if you were listening to this, thanks for listening in, and much appreciated.